Welcome to the Rad-On Smart Review CNS Cancer series. In this session, we're really going to push the frontiers of stereotactic radiosurgery for brain metastases. We'll be tackling some of the toughest clinical questions you'll face as residents. Things like, how do we effectively manage multiple brain metastases? What's the best way to treat really large lesions? And then that ever-present diagnostic challenge, how do we confidently differentiate radiation necrosis from actual tumor progression? These are common, and complex scenarios, and our goal is really to give you a comprehensive understanding to help refine your clinical decision-making.
That sounds like a perfect mission statement.
Yeah.
For many years, stereotactic radiosurgery, SRS, it's rightly been the established standard for patients presenting with 1 to 4 brain metastases. But what's truly exciting is how the field is continuously evolving, kind of challenging those initial limits and pushing the envelope further, to give our patients the best possible outcomes.
Okay, let's maybe unpack this with a couple of patient scenarios. That should bring these challenges to life. First up, imagine patient A, 62-year-old man, metastatic melanoma. His systemic disease is actually very well controlled on immunotherapy, but a routine surveillance brain MRI reveals 8 new small brain metastases. And when I say small, all of them are less than 1 centimeter. Now, historically, a patient like this, well, they would have been almost an automatic candidate for whole brain radiation therapy, WBRT. But what does the modern evidence tell us about that approach now?
That's a crucial point, yeah. It really highlights the dramatic shift in our thinking, our paradigm. We used to be quite rigid about just the sheer number of lesions, but as we'll delve into, newer data has significantly broadened our perspective. It's moved our focus toward the overall burden of disease, the total tumor volume, rather than just a hard numerical count.
Understood. Okay. Now let's consider patient B. This is a 58-year-old woman, renal cell carcinoma. She presents with a single 2.5 centimeter metastasis in her right parietal lobe, minimally symptomatic, which is certainly good news. However, a key challenge arises here. A single high dose of SRS to a lesion of this size carries a significant risk of toxicity to the surrounding healthy brain. So what's our primary alternative for a patient like patient B?
That's a critical consideration, absolutely, for patient safety. While SRS is incredibly potent, applying a single very high dose to a larger volume can, unfortunately, lead to unacceptable side effects. Our strategy absolutely needs to adapt to the size of the target to ensure both effective tumor control and, well, optimal safety for the patient.
And that brings us perfectly to our first look at the trials and evidence, specifically challenging that old dogma around lesion count. For years, SRS was, by common practice, pretty much limited to 1 to 4 brain metastases. That limitation largely stemmed from the inclusion criteria of the earliest trials. But then came a landmark study that genuinely shook things up. The Japanese Prospective Observational Study, JLGK 0901.
Precisely. This study, published by Yamamoto and colleagues in the Lancet Oncology back in 2014, it was truly practice-changing for us. It was a massive prospective registry enrolling nearly 1,200 patients, all treated with SRS alone. What was key was their comparison. They rigorously looked at outcomes for patients with 2 to 4 metastases versus those with 5 to 10 metastases.
And what did they find? Because this is where it gets really interesting for our daily practice, right?
The crucial finding, the headline really, was that there was no significant difference in overall survival between those two distinct groups. The median overall survival was 10.8 months for both the 2 to 4 and the 5 to 10 metastases groups. Even neurologic death rates and the need for salvage therapy were remarkably similar. This powerfully demonstrated the safety and efficacy of SRS beyond what we traditionally considered the numerical limit.
Wow, that's really quite something. So it opens the door for treating more lesions than we might have thought possible before. But there was a critical caveat, wasn't there? This wasn't just a free pass for all patients with many metastases.
Indeed, that's an absolute vital detail. You have to remember the trial had very strict volume limitations. The largest single metastasis couldn't exceed 10 cubic centimeters. And critically, the total tumor volume across all lesions had to be less than 15 cubic centimeters. This is the clinical pearl here. The Yamamoto trial taught us that for prognosis and SRS eligibility, total tumor volume is more important than simply counting the number of metastases. This entirely changed our approach to patients like patient A.
That's a massive shift in thinking, moving us from just a numerical count to a more nuanced, volume-based assessment, which, intuitively makes a lot of sense from a radiation biology perspective. Now let's swing back to patient B, our 58-year-old with that 2.5 centimeter metastasis. We highlighted the challenge of a single high dose for a lesion that size.
Yes. If we look back at the dose escalation data from the RTG-9005 trial. The maximum tolerated single-fraction dose for a lesion of 2.5 centimeters is only 18 gray. That's a unit of absorbed radiation dose. The problem is, that dose provides pretty suboptimal local control. Failure rates are up around 40 to 50%. And if you attempt to push a higher single dose, you regrettably run into an unacceptable risk of radiation necrosis.
So if a single high dose isn't really the answer there, what is our best alternative?
The solution lies in what we call fractionated stereotactic radiosurgery, or FSRS. By splitting the total dose into typically 3 to 5 fractions, we can exploit the principles of radiobiology, the differential response between tumor and normal tissue, to significantly improve the therapeutic ratio. That's that crucial balance between achieving tumor control and minimizing damage to healthy tissue.
And there's some really strong evidence supporting this, right? The Maniti analysis from 2016 comes to mind. This is a key retrospective analysis that directly compared outcomes for large metastases treated with either single-fraction SRS or multi-fraction SRS, typically 27 gray and 3 fractions. What were the results there? They were quite striking.
You were really compelling, yes. The 1-year local control rate was significantly better with fractionation. It came in at 91% compared to 77% for single-fraction SRS. And perhaps even more importantly, the rate of radiation necrosis was cut in half. It dropped from 18% with a single fraction down to just 9% with 3 fractions.
That's a huge improvement in both efficacy and safety. So it seems pretty clear that for intact brain metastases larger than, say, 2 to 3 centimeters, a fractionated approach like 27 gray and 3 fractions should really be our standard of care now.
Absolutely. The evidence is, well, it's unambiguous. It's a definite game changer for these larger lesions, allowing us to treat them much more safely and effectively.
Now, you just mentioned radiation necrosis, and it's a complication we unfortunately do encounter. It's often the primary concern with SRS. And differentiating it from true tumor progression is undoubtedly one of the most difficult challenges in neuro-oncology. Let's start with prevention, though. How can we best minimize that risk during the critical planning phase?
That's a crucial first step, truly. The most important dosimetric predictor, the thing we really look at for symptomatic radiation necrosis, is what we call the V12. This refers to the volume, V, of normal brain tissue that receives 12 gray, the 12, or more, in a single fraction. Multiple retrospective series have consistently shown a clear dose-volume relationship with this specific parameter.
Okay, so what's our practical dosimetric goal for that V12 when we're actually planning these treatments?
To keep the risk of symptomatic radiation necrosis below about 10%, our aim, our goal, is to keep the total normal brain V12 less than 8 to 10 cubic centimeters, less than 8 to 10 cc's. If a plan, for whatever reason, requires a V12 greater than this threshold, it's a very strong indication, a red flag, really, that you should seriously consider switching to a fractionated approach instead of that single fraction.
That's a great actionable insight. To really help grasp this V12 concept, do you have maybe an analogy that helps it click?
Certainly. Yeah, I like this one. Imagine a really delicate circuit board, like inside your computer, with critical components really close together. The V12 is kind of like the amount of heat spreading into those critical components when you're soldering something nearby. Even if the overall system is still running, if too much of the board's sensitive wiring gets heated above a certain critical temperature, that's our 12 gray threshold, you're at high risk for a short circuit or permanent damage down the line. In radiation, that heat is the radiation dose. And if too much normal brain tissue hits that 12 gray mark, you're increasing the odds of symptomatic radiation necrosis. It's all about precisely limiting that collateral damage on those critical pathways.
That analogy really helps clarify it. Okay, now, moving to the diagnostic challenge. When a patient comes back for a follow-up MRI and you see a new or maybe an enlarging, enhancing lesion, how do you actually tell a difference between radiation necrosis and tumor progression? This can be incredibly stressful for both the patient and for us.
It absolutely can be. And this is where advanced imaging becomes really indispensable. And for board exams, there's a great mnemonic to remember the key modalities. The 3 Ps.
Yes, the 3 Ps. Okay, what do they stand for?
The 3 Ps stand for perfusion, PET, and protons from spectroscopy. First, perfusion MRI. This measures relative cerebral blood volume, or RCBV. In simple terms, a tumor is metabolically hot. It needs a lot of blood supply, so it shows increased blood flow. Necrosis, on the other hand, is damaged tissue. It's cold, and it will show decreased perfusion.
Makes sense. And the second P?
That's a PE scan. usually using FDG as the tracer, which measures metabolic activity. Just like with perfusion, tumor is metabolically hot. It's actively growing, consuming glucose, so it shows high uptake of the tracer. Necrosis is metabolically cold, much lower uptake.
Okay, hot versus cold again. And finally, the third P, protons from spectroscopy. I always remember the phrase choline for cancer.
Precisely. That's the key takeaway. MR spectroscopy measures the chemical composition of the tissue non-invasively. If it's true tumor progression, you'll see an elevated choline peak that's choline for cancer, because choline is a building block for cell membranes, elevated in rapidly dividing cancer cells. Radiation necrosis, conversely, will have a low choline peak, and often you'll see an elevated lactate peak, which indicates cellular breakdown and anaerobic metabolism. This chemical fingerprint can be really quite definitive.
Those are fantastic tools for making those tough clinical calls. All right, it's time to lock in these key takeaways from our discussion. Let's get to our clinical pearls.
Okay, pearl number 1. For patients with multiple brain metastases, remember that total tumor volume is more important than simply the number of lesions when you're determining prognosis and SRS eligibility. The JLGK0901 Yamamoto trial supports using SRS for even 5 to 10 metastases, provided that total tumor volume is less than 15 cubic centimeters. Volume, not just count.
Pearl number 2. For intact brain metastases that are larger than 2 centimeters, remember fractionated SRS, for example, 27 gray in 3 fractions is superior to a single fraction SRS approach. It gives you both better local control and a lower risk of radiation necrosis.
Pearl number 3. The single most important planning constraint for predicting symptomatic radiation necrosis after single fraction SRS is the normal brain V12. Your goal should be to consistently keep that V12 below 8 to 10 cubic centimeters.
And finally, pearl number 4. To confidently differentiate radiation necrosis from true tumor progression, you need to use advanced imaging. Remember the 3 Ps mnemonic. Necrosis is cold on perfusion MRI and PT scans. And on MR spectroscopy, it will show low choline and high lactate. Tumor, of course, is pretty much the opposite profile.
That's a comprehensive and concise overview of those critical points.
Okay, now let's really test your understanding of these advanced concepts in our board blitz. Ready?
Ready as I'll ever be. Let's do it.
Question 1. What was the primary conclusion of the prospective observational study by Yamamoto regarding the use of stereotactic radiosurgery for patients with multiple brain metastases? Was it A, SRS is only effective for a maximum of 4 metastases? B, overall survival was non-inferior for patients with 5 to 10 metastases compared to those with 2 to 4 metastases. C, patients with more than 4 metastases had unacceptably high rates of radiation necrosis. Or D, neurological death rates were significantly higher in the 5 to 10 metastases group.
Okay. The best answer there is B. The Yamamoto 2014 study was really practice-changing because it showed no significant difference in overall survival between patients with 2 to 4 mets and those with 5 to 10 mets, provided the total tumor volume was limited. It genuinely shifted our thinking away from just rigid numerical limits.
Excellent. Okay, let's dig into another critical scenario. Question 2. For a brain metastasis measuring greater than 2 centimeters, how does treatment with multi-fraction SRS compare to single-fraction SRS based on the retrospective analysis by Maniti? A, similar local control and similar rates of radiation necrosis. B, inferior local control but a lower rate of radiation necrosis. C, superior local control and a lower rate of radiation necrosis. Or D, superior local control but a higher rate of radiation necrosis. All right, the best answer here has got to be C. The Maniti analysis showed a really clear and compelling advantage for fractionation in these larger metastases. Multi-fraction SRS was associated with both significantly better 1-year local control, 91% versus 77%, and a significantly lower rate of radiation necrosis, 9% versus 18%. Better control, less toxicity.
Perfect. Okay, one more to really solidify our understanding of planning constraints. Question 3. Based on multiple analyses, what total normal brain volume receiving 12 grays in a single fraction, the V12, is generally considered a threshold above which the risk of symptomatic radiation necrosis significantly increases? Is it A, less than 2 cubic centimeters, B, less than 4 cubic centimeters, C, less than 8 to 10 cubic centimeters, or D, less than 15 to 20 cubic centimeters? The best answer is C, less than 8 to 10 cubic centimeters. The V12 is such a critical dosimetric predictor. Multiple retrospective series have consistently shown that keeping the V12 below that 8 to 10 cc range is associated with a low risk of necrosis, generally less than 10%. It's really a cornerstone of safe SRS planning.
Fantastic job on the board blitz. Now, we've covered a lot of ground on the established best practices and the key trials that support them, but beyond what's now considered sort of standard of care, what's truly on the cutting edge? What's a major shift or maybe an ongoing debate that our listeners, as future experts, really need to be thinking about when it comes to CNS radiation oncology?
Yeah, that's where it gets truly fascinating and maybe a bit controversial still. These findings we've discussed, they definitely represent a significant advance. We've moved beyond those rigid numerical limits, pushing for more personalized volume-based treatment. That's huge. But the controversies continue. For example, if total tumor volume is truly the key driver, are we still being too conservative with patients who present with a very high number of small brain metastases, say 15 or 20 tiny lesions? Is there a point where the sheer number itself just becomes too unwieldy to treat safely and efficiently with SRS, regardless of the total volume, or maybe just too time-consuming? And then there's a whole complex interplay with emerging systemic therapies. How do novel immunotherapies and targeted agents truly reshape our SRS strategy beyond the basic principles we've discussed today? This is where active debate and ongoing research are really pushing the boundaries now.
It's incredible to see how quickly the field evolves, isn't it? Constantly refining our ability to treat these complex cases. So, just to bring it all together, let's quickly recap the core concepts from today's session.
Okay. First, we established that SRS can be a safe and effective option for patients with 5 to 10, maybe even more, brain metastases, provided that the total tumor volume is low, less than 15 cc's. That's the big takeaway from the Yamamoto trial, volume over number.
Right. Next, for large metastases, specifically those over 2 centimeters, we learned that fractionated SRS, something like 27 grays in 3 fractions, gives you superior local control with significantly less toxicity, less radiation necrosis, compared to single fraction approaches.
And we also hammered home the critical V12 constraint, keeping that volume of normal brain getting 12 gray or more below 8 to 10 cubic centimeters. That's key to minimizing radiation necrosis risk in single fraction treatments.
And finally, we reviewed how to confidently differentiate radiation necrosis from tumor progression using advanced imaging, remember the 3 Ps? Perfusion MRI, PET, and MIMR spectroscopy. Necrosis is generally cold on the first two, and on spectroscopy it shows low choline and often high lactate. Tumor is basically the opposite profile.
That's a pretty good summary of some really advanced but crucial concepts in CNS radiation oncology for brain metastases.
Definitely. In our next session, we'll delve into the complex interactions of SRS with immunotherapy and targeted therapy, another really hot topic. For show notes and to complete practice oral boards, remember to visit radoncsmartlearn.com. That's radonkSmartlearn.com. And be sure to subscribe to Radonc Smart Review for our next session. Thanks so much for tuning in.
And just a final thought, always remember in oncology, evidence is a dynamic force. It's constantly shifting. Continuously reevaluating established paradigms based on new data isn't just, an academic exercise. It directly leads to better patient care. So keep questioning and keep learning.